Hello, my name is Dr. Guillermo Loyola, a first-year internal medicine resident at the University of Florida, Jacksonville. Today, my colleagues and I will be presenting a rare complication of compressive myelopathy following open heart surgery. So, open heart surgery is often life-saving, but it is a procedure that carries inherent risk and potential complications. Some of these complications include neurological complications such as strokes and TIAs. However, compression myelopathy is a rare and frequently under-recognized complication. Today, I will be presenting a case report describing a 30-year-old female with a complex open heart surgery for a right atrial mass, and we're going to be talking about the presentation, the diagnosis, and the management of this compression myelopathy. A 30-year-old woman was admitted for DKA, diabetic ketoacidosis, and was found to have Klebsiella bacteremia in the setting of a complex medical history that included ESRD on hemodialysis, insulin-dependent type 1 diabetes, hypertension, and a right atrial mass. The patient was started on antibiotics upon admission and therapeutic anticoagulation for a right atrial thrombus, and a tunneled catheter was identified as the source of the bacteremia, and it was removed. During hospitalization, she developed multiple pulmonary nodules consistent with septic emboli from the thrombus. An initial angiovac procedure removed only 5 to 10% of the right atrial thrombus, and thus consultation with cardiothoracic surgery was sought. The patient underwent successful excision of the cardiac mass, the right atrial reduction and atrioplasty, and left lung decortication. The next day after surgery, she suddenly developed acute lower extremity paralysis without any other focal neurological deficits. The initial MRI, the thoracic and lumbar spine was unrevealing. This MRI was done without contrast. The continuation of symptoms led to further imaging in the form of an MRI of the cervical, thoracic, and lumbar spine, both with and without contrast. The cervical and the lumbar MRIs were unremarkable. However, the thoracic MRI revealed an abnormal signal within the spinal cord at T2, T5, suggesting edema and flattening of the cord due to a prominent posterior epidural space and reduced cerebrospinal fluid space ventral to the cord. This could be seen on the images to the left. The top image shows an axial T2 weighted MRI showing significant spinal stenosis, and the bottom image shows a sagittal T2 weighted MRI showing decreased conspicuity of the abnormal cord signal in the thoracic cord spanning from T2 to T5. We also pursued a lumbar puncture that revealed albuminal cytological dissociation, which initially we thought the patient might have developed a post-op GBS, Guillain-Barré syndrome. However, after extensive discussion with neurology and CT surgery and follow-up imaging, including DWI, diffuse weighted imaging, suggested compressive myelopathy. The patient was treated with dexamethasone 4 milligrams twice a day and improved neurologically with proximal leg strength, improving from 0 out of 5 on post-op day 1 to 3 out of 5 in the following 5 days. This case was intriguing as the acute lower extremity paralysis began right after surgery. The differential diagnosis included transverse myelitis, GBS, spinal infarction, and ultimately compression myelopathy. Initial imaging and clinical evaluation combined with unrevealing MRIs of the cervical and lumbar region suggested that this was the non-inflammatory, non-ischemic pathogenesis, and we ultimately decided that this was a mechanical compression attributed to the intraoperative positioning or surgical factors. Her improvement with corticosteroid therapy further supported this diagnosis of compression myelopathy. This case highlights the importance of a comprehensive and multidisciplinary approach for diagnosing complex post-op complications. As mentioned, the differential diagnosis process was thorough and methodical, considering and ruling out each potential cause on the basis of clinical and diagnostic findings. Most of the cases that we found in the literature consisted of ischemic myelopathy and cervical spine involvement. However, our case was a thoracic spine involvement and it was non-ischemic. It was the compression myelopathy. This case emphasizes the necessity for vigilance and detailed assessment in patients presenting with atypical neurological deficits following major surgeries. Thank you so much for your time.